Hello, everybody. I would like to welcome you to our third progress report. My name is Xenia Jockers, and my topic is the identification of predictive and prognostic factors in polyposis syndromes. I'm a pediatric resident at Semmelweis University 2 Salto Street Department and a PhD student. My vision is to enhance chances of survival and quality of life in patients with polyposis syndrome. And my mission is to develop an accurate diagnostic and management protocol by monitoring through the genotype-phenotype association. Currently, I have two ongoing topics. And the first one is investigating the association between the genotype and phenotype of pediatric patients with polyposis syndrome, where we would like to develop a systematic review and a meta-analysis. Shortly about the background. Polyposis syndromes are a group of hereditary diseases characterized by multiple gastrointestinal polyps and increased risk of cancer and other conditions. Its prevalence is 1 to 20,000, and they are caused by genetic mutations which alter the function of the affected genes. Thanks to modern diagnostic methods like new generation sequencing, it is possible to detect these mutations, but until today, there is no clear genotype-phenotype correlation been demonstrated in most of these diseases. In addition, these diseases show very rare appearance of cancer and other conditions, and on these grounds, the recommendation regarding the management and treatment options for polyposis syndromes remains very poor. Therefore, the aim of my study is to investigate the possible outcomes in association with the genetic background in pediatric patients with polyposis syndrome, to implement an early diagnosis, predict the course of the disease, and find the best management protocol and therapy options to improve the quality of life for these patients and enhance chances of survival. My clinical question is, what is the association between the genotype and phenotype in children with polyposis syndrome? And we use the PO framework, where my population is children with polyposis syndromes, which you can see on the side. The exposure is the genotype variances of polyposis, and the outcomes are the different phenotypes with the type of the disease, the clinical features, including the onset, the course, and the manifestations. My hypothesis is the genetic variances the syndromes can be associated with clinical variabilities. For the systematic search, we used the search key that you can see below, and in the end we had 18,495 hits, of which we had 144 eligible full-text articles. We started, after the data extraction, we started our analysis with the Poytz-Jeghers syndrome, which shows a mutation in the STK11 gene. We divided our analysis into two groups. One was the phenotype with its clinical manifestations, where we had the differences between the intestinal manifestation and the extraintestinal manifestations. And the second part of the analysis was about the genotype of the Poytz-Jeghers syndrome, where we located the exact mutation and the type of the mutation. And afterwards, we performed a variant interpretation by the American College of Medicine, Genetics and Genomics. They categorize mutations into 5 groups according to 28 criteria, which go from 1 benign to 5 pathogenic. On the following slides, I would like to show you some of my results. The first one is about the phenotype of Poytz-Jeghers syndrome, where we used mostly case series and case studies. In the end, we had 93 patients, and with these results, I would like to show the intestinal and one extra-intestinal outcome. So the first one is that although we are talking about the polyposis syndrome, not every patient is showing symptoms in the GI tract. Here we can see that patients that only 67% of the patients had polyposis in the lower GI tract, and almost 40% showed involvement of the upper GI tract. But on the other hand, an extra-intestinal manifestation, which is very typical for Poytz-Jeghers syndrome, is the melanocytic pigmentation, mostly around the mouth or on the hands. Here we can see that out of the 93 patients, we had only 9 patients who did not show these symptoms. The rest, all of them showed melanocytic pigmentation. Some of these patients did not have polyposis. So in conclusion, we can say that although we are seeing symptoms that could be part of a polyposis syndrome, we should not exclude it if we are not seeing any GI involvement. The next chart I would like to show you is about the variant interpretation and the phenotype of these patients. Here we had 82 patients to analyze, and we used the ACMG variant interpretation I talked about previously, which went from 1 benign, 2 likely benign, 3 uncertain, 4 likely pathogenic, and 5 pathogenic. As you can see in this chart, we did not have any patients in the second group, which is likely benign. And what is interesting about this is that benign mutations should not show any effect on the protein synthesis, while pathogenic mutations can lead to malignant transformations in these diseases. Here we can see that we had one patient who had a benign mutation but showed an extraintestinal tumor. And after talking to a geneticist, this could be due to another mutation, but the article did not mention any other outcome. The other thing that we can see that no matter in which group we are, every patient shows polyposis, either in the upper GI, in the small intestine, or in the lower GI. But extraintestinal tumors are usually in the groups of pathogenic mutations. So according to this, in conclusion, we can say that we cannot predict the course of the disease depending on the type of the mutation so far. But here on this chart, we can see that pathogenic and likely pathogenic mutations appear earlier, with an earlier onset around 4 years, than benign mutations, where our average onset was with 6 years. The strengths of my study are that we have individual patient data and a uniform reporting of the clinical manifestations and detailed information about clinical manifestations, but we have a low patient number since it's a very rare, since they are very rare disorders, and they use different diagnostic procedures looking at the genotype for these patients, and even the description of the genotype differed from article to article. I would like to go on with my second topic, which is investigating the association between the vitamin D levels and malignant transformation of intestinal polyps in pediatric patients with polyposis syndrome, where we would like to develop a systematic review and meta-analysis and a prospective multi-centered study. Shortly about the background, colorectal cancer is the third most common cancer in both sexes, and patients with polyposis syndrome have a high risk to develop colorectal cancer. For example, in familial adenomatosis polyposis syndrome, the prevalence is 100%. So the question arises if there is a way to prevent this malignant transformation and if we could start prevention in childhood. In previous studies, we saw that vitamin D as a chemoprevention is possible due to its anti-proliferative, pro-apoptotic, and immune modulatory effects. So our clinical question is if the vitamin D level influences the disease course in patients with polyposis syndrome. Here we would like to use the PICO framework, where our patients are pediatric patients with polyposis syndrome. The exposure is a low level of vitamin D. The comparison is a normal level of vitamin D. The first outcome would be the malignant transformation, and the second outcomes are the onset, disease course, and chemoprevention. Our hypothesis is that low vitamin D levels have an effect on the course of the disease, affect the course of the disease negatively in patients with polyposis syndromes. To summarize, the aim of my study is to gain a comprehensive understanding of polyposis syndrome, look through the genotype-phenotype association, and find the best management and therapy option for these patients. Let me finish with one of my favorite quotes. Learning and enjoyment are the secret to a fulfilled life. Learning without enjoyment wears you down. Enjoyment without learning dulls you. Thank you very much.
Thank you. Congratulations. It's a really nice work. So, Mike, I have a question related to your first topic. How this genetic testing fits to the clinical practice. Is it a screening tool or is it a diagnostic tool?
It's a diagnostic tool. Like previously, polyposis syndrome was a clinical diagnosis based on endoscopic outcomes, but today they have to do a genetic testing as well to make sure they have a polyposis syndrome. So by today it's a diagnostic tool.
Can the early diagnosis prevent somehow or improve the future outcome?
Well, I hope yes. So far, polyposis syndrome is a disease which is mostly managed by gastroenterologists, and the oncological side is very poor, basically. So we are hoping to, if we have an early diagnosis and we can see what type of mutation we have, to make a better management protocol even for the malignancies, not only from the side of the gastroenterologist, and maybe even prevent the malignant transformation in adulthood from polyps to colorectal cancer.
I would have one question regarding your second project. Vitamin D levels, the cutoff for hypovitaminosis are very vary between different guidelines. How you are going to deal with that? And also the second question, also the value of vitamin D is different during the year, with the sunny periods, etc. How you are going to deal with these confounders?
Yes, so thank you for your questions. We're not only want to look at the vitamin D levels like in the whole body, like from the blood from the patients, but we want to look at the vitamin D levels and the vitamin D receptor levels in the polyps, and if they have an effect on the transformation or in the malignant transformation, because previously it was shown that those tumors who have lower level, they transform faster than others. So that's basically, so we want to look at the polyps itself to see what is going on there with the vitamin D levels, and then of course also at the vitamin D level of the patients themselves, but we did not put that into a range yet.
Thank you.
So thank you for your presentation. I have one question about your first project, about Pred-Seeger syndrome.
Yes.
If patients have mutation in STK11 gene mutation, how frequently colonoscopy have to be performed to see future polyposis? For example, they don't have clinical presentation but have mutation.
Mm-hmm. Thank you very much for your question. So it actually depends on if it's a sporadic mutation or if it's a hereditary mutation, like if we know it's from the family or not. Because if we have the mutation, but we have it in, for example, in an early age, because the father, for example, has this mutation, we don't have to do a colonoscopy before the age of 8 years, because usually the polyps appear after the age of 8 years. And depending on the picture that we can see there, if there are a lot of polyps, or if there is only one polyp, or if there is even no polyp, it's categorized to do a colonoscopy in time range from 1 to 2 years if there are no polyps, and it goes from if there are a lot of polyps every 6 months, and if we can see any transformation due to a pathogenic mutation, it is recommended to do a colonoscopy every 3 months.